Thank you. Good morning, everyone. This is Michelle Consolazio with the Office of the National Coordinator. This is the last public in-person meeting of the Health IT Policy and Health IT Standards Committee. This is a public call, and there will be time for public comment before lunch and after lunch. And we will take roll today by going around the room. But before I do that, just a reminder, if you could state your name before speaking, as this meeting is being transcribed and recorded, it would be appreciated. And we will start with Lorraine Dew from CMS.
Lorraine Dew with the Centers for Medicare and Medicaid Services.
Kyle Metters, Chartlux.
Raj Dash from Duke University.
Dr. Ann LeMater from Ascension.
Angela Kennedy, Louisiana Tech University, Consumer Advocate.
Brent Snyder, Adventist Health System, Orlando.
Leslie Kelly Hall, HealthWise.
Andy Wiesenthal, Deloitte Consulting.
Kim Schofield, the Lupus Foundation.
Kay Aaron, Intel.
Aaron Miri, Improvato.
Jatan Asnani, Commonwealth Health Alliance.
Anjum Khurshid, Dell Medical School, Austin.
Larry Wolf, Strategic Health Network.
Gail Harrell, State Representative from Florida.
John Fleming, Deputy Assistant Secretary for Health IT Reform.
John White, Acting National Coordinator.
Mary Malik, Change Healthcare.
Paul Tang, IBM Watson Health.
Lisa Gallagher, PwC.
Kathleen Blake, American Medical Association.
Steve Posnack, ONC.
Elise Winnie Anthony, ONC.
Kim Nolan, Pfizer.
Jamie Ferguson, Kaiser Permanente.
Eric Rose, Intelligent Medical Objects.
Carolyn Peterson, Mayo Clinic.
Terry O'Malley, Partners Healthcare, Boston.
Karen Banqualo, Florida Healthcare Coalition.
Ram Shriram, National Institute of Standards and Technology.
Nancy Orvis, Department of Defense.
Lloyd Eisenberg, iParsimony.
And on the phone, we have Josh Mandel.
Yes, good morning.
Hi, Josh. Wename Oi.
Hi, hello, it's Wenme.
Good morning. Peter Johnson.
Good morning.
Donna Cryer. Hi, Peter.
This is Donna, and I so wish I could be with you over there in person.
Thanks, Donna. Paul Eggerman.
Good morning.
Hi, Paul. Troy Siegenthaler.
Good morning.
Hi, Troy. Steve Brown.
Good morning.
Are there any members on the line that I missed?
This is Kevin Johnson.
Hi, Kevin. Okay, with that, I'm going to turn it over to John White to make a few opening remarks.
Oh, all right. Thank you very much, everybody. Good morning. I am so glad that you all are here. Welcome to spring in D.C., finally. I'd like to take just a quick opportunity to just personally thank you all. It will be a day full of thanks, and that is a good thing. But I'm incredibly grateful for not just your presence, but for your commitment. You are all incredibly talented people, and you're all incredibly accomplished people, and you're busy folks. So for you to carve out not just a chunk of today, but every day that you do this, and drag yourself to the Washington Plaza Hotel, and to sit here and to think hard with us about the things that we're grappling with, in service of the American public, and to give us that good, strong advice that we need is, just a comfort that I cannot measure to you for those of us who are doing this. And I know that it's a lot of effort on your part to do that, and it's a lot of commitment. Thank you. Thank you for that. I really want to personally thank you. I also want to say, just kind of give you a brief update on things. It's been a busy time. We've been keeping ourselves, working hard, doing lots of good stuff. Not just at ONC, but across HHS. Of course, as you know, we have a new secretary, Dr. Price, and I am pleased to be able to tell you that the good Dr. Price has an unwavering commitment to improving interoperability, using health IT to get to a better healthcare delivery system and for better health for the nation, and to reduce the burden that the use of these information systems has for our clinicians that we've all heard about and that we all know about. And I know that that's something that probably every one of you around the table is committed to too. So that's reassuring to know that the leadership is there with us, and that as they kind of are getting settled, that they are pointed in the same direction that we are. So that's good. Of course, we will continue to work closely with our esteemed and valued federal partners, some of whom are here around the table with us, some of whom are on the phone, and with the private sector to be able to do what we do. We're especially looking forward, as I've mentioned to you before, working on 21st Century Cures, which is the culmination of a long and thoughtful legislative process, and has several important directions for ONC as well as specific tasks to be working on. So we're looking forward to implementing that. But for those of you here in the room and listening on the phone, probably the big news is the gentleman to my right. So it is my pleasure to be able to introduce to you our new Deputy Assistant Secretary for Health IT Reform, Dr. John Fleming. I will say to you that John and I were introduced in a late-night phone call, and it has been a joy and a pleasure to have him at ONC. He has been unfailingly kind and courteous and deeply interested in what we're doing. I'm going to give him a chance here to introduce himself to you, but we've enjoyed having him at ONC, and I'm pretty sure you guys are going to enjoy having him as part of our larger community. So, Dr. Fleming.
Well, thank you, John, and let me say that I have to practice giving my title. It is so long that I have to work on it, and I've noticed that in Washington there's an inverse relationship between the length of your title and how important you are. So that should tell you something. So anyway, my practice history, I am a physician, a family physician. My practice history goes back to the Paleozoic era. I actually entered med school only 3 years after family practice became a boarded specialty, and graduated in '76. I was a military. Did my residency in the Navy, but then served in the military, and then set up my private practice in 1982, back in the golden era of Medicare, before we had RBRVS or any of those things. And of course, I've lived through all of these developments and evolutions. And but I can recall that while I was actively practicing medicine in the hospital, how frustrated I was that when time came to see the patient, there was not lab, there was not X-ray. What happened to it? And that was always a and I got pretty grouchy, I have to admit, when it came to those things. But in 2009, I entered Congress. I've been serving there until this past January. And along the way in my medical practice, I did see a future in electronic health records. As far back as 1997, we implemented the first, as far as I know, the first private practice EHR in Louisiana, and we were paperless by 1999. And believe it or not, we actually were able to drop off one FTE, one full-time employee, not a specific person, but we just through attrition actually ended up with fewer employees. Why? Because we figured that with our paper chart, there was at least one employee at any one time searching for either lab or a chart. The chart could be on a doctor's desk. It could be in the chart cabinet. It could be up for dictation. It could be up for lab. It just, it was a constant search. And we became much more efficient, and we developed our practice workflow and electronics. We developed our practice around electronics in our workflow, and it worked very nicely. Then came meaningful use. And what we found was the vendors were having difficulty helping us meet those requirements. And so we're now, my practice back home, which I'm having to divest myself of, but they're nearly on the third generation of records, because that oftentimes meeting the needs that we in Washington ask and the needs of the doctor have not always coincided. So I'm very excited working with John and Annie Gettinger and many others that I've met, extremely competent people who've been with us a long time, and certainly you can tell I have a passion for this, because I really believe that the future of healthcare is highly dependent on the central and peripheral nervous system that electronics, the healthcare IT provides for us. So I look forward to meeting others here today whom I've not met, but also working with you going forward, because I see exciting things coming for the future. Thank you.
All right. Like I said, he's a good guy. All right. So with that, I do hope that during the break and when you get a chance, please come up and say hello to Dr. Fleming. I know he will want to meet you all. With that, I will turn it back to Michelle. Thank you.
Thank you, John. I'm going to turn it over to Kathy Blake to review the agenda and approve the minutes from the March 8th meeting.
Thank you, Michelle, and thank you, Dr. Fleming. We look forward to working with you. And so I'll now, with respect to the agenda, we have two main topics today. At our last meeting, we heard from the Public Health Task Force. They're coming to us today now with having received a great deal of input to present their recommendations, which will be submitted for a vote for approval. Following that, we'll then hear public comment, break for lunch, and then hear from the Consumer Task Force. It will be an update from them, and they'll be discussing with us the patient-generated health data draft white paper and requesting our feedback. There'll be no other action required on that. I'd like next to present to the combined committees the minutes from our March 8th meeting and would entertain a motion for approval. And we'll entertain a vote now for approval of the March 8th meeting minutes. All in favor? Aye. Any opposed? And any abstentions? And for the members on the phone, any votes from them? I think the minutes have been approved by a majority vote, but we'll record their votes if we need to. Thank you. I'll now turn things over to my co-chair, Paul Tang.
Kathy, and I'd like to welcome the Public Health Task Force to the table, please. As you recall from our virtual meeting, we had a presentation of the draft recommendations. We provided some feedback, and the task force has been working on the feedback to revise it. This is going to be something we want to take an action to approve. Hopefully we'll approve it since it's our last meeting, at least face-to-face. And you recall last time I pointed out the intersection, really the integration of public health and individual health. So clearly the public's health affects the individual, witness Zika virus, and clearly the individual's health affects the public, for example, antibiotic resistance. So this truly is a one health kind of concept. It's a global health. And so in order to facilitate how we accommodate the needs of public health in our records, the Public Health Task Force is making some recommendations about how HIT should incorporate these needs. So take it away, Larry and Annie.
Okay. Well, it's really good to be back here. I think this is a really exciting topic, a lot that we can do to make things better, both in the short term and the long term. And it's really been a pleasure working with Annie and the whole of the task force. And I'd like to also specifically thank the support from ONC. So Jim Daniel, who was part of the task force, really brought a depth of expertise on public health. Rachel Abbey and Douglas Wilson were both really key for the support of making all this come together. It really made it possible for the task force to do its job. So a big thanks to them and to all of the expertise that the task force members brought. So a quick outline of what we're going to go over. We'll remind you of the charge and the principles that we were working with, our overall recommendations at the beginning, and then we will walk through how we got to those recommendations and dive into some of the specifics around each of them, and then end with a summary so you can see what we're asking you to approve. And then there'll be some public comment. So the overall charge here is as a public health task force. So that was the context in which we're working, but really focusing on the health IT aspects of that charge. So we didn't look to move ahead any guidance on how to manage a public health crisis, but how to use the tools that we have, both the human and existing processes, and where we can leverage health IT. And then specifically looking at issues around Zika as our use case, if you will, and also as one that really needs continued attention and focus with a real sense of urgency. So we focused in 4 areas: capturing pregnancy status because of the important implications for pregnancy with respect to Zika, making sure that then gets transmitted along to public health agencies, that there's increased use of clinical decision support. We'll go into some of the examples of why that's important, and also how to improve electronic case reporting. And we put forward some principles to try to keep us focused in the work that we were doing, so everything from clarity of purpose to really understand what it is we've been asked to do and staying on task with that, to finding the bright spots. Where's this already working? Let's learn from what's actually working in the field. And make sure that we engage a broad set of stakeholders. Be parsimonious. Let's be focused in what we recommend. Let's look for generality. Zika is not the only public health issue that needs to be addressed, and there will be other emerging diseases in the future. So let's continue to build on the history of what's been done and go forward with that. Looking for things that are pragmatic and actionable. Looking to balance priorities because there's a lot of different demands being made on all of the stakeholders, healthcare providers, their IT vendors, the labs, and public health as well. And finally, that wherever we can, to be looking at national scale. So a bright spot might be bright because of local conditions, but where can we really bring it to national scale? So we'll walk you through sort of the overview of who are the main constituents here. So we have public health really is kind of the linchpin around which all this circulates. Individuals who are looking to maximize their own health and avoid risks. Healthcare providers who are the hands-on people who make it all work. And the laboratories that play an absolutely essential role with things like Zika. And so the initial action here is guidance coming out from public health, and that is distributed in many ways today, and specifically in terms of where we focused with clinical decision support. How can we build on the guidance that's there and make it more embedded in the workflow because it's part of useful clinical decision support and not triggered inappropriately. And we also have healthcare providers offering guidance to to individuals as patients and through their websites and apps. And we looked at collecting information from individuals about their own health that they could then supply back to their healthcare providers. And so there could be a lot of forms in which that happens, and the line ought to be hashed to indicate that this is a work in progress. So we know that there are beginnings on this work, but there isn't a lot to actually build on for immediate action. Once a healthcare provider feels like someone has qualified for some further investigation, they might order some lab work with a specimen that would go to a lab. And then when the reports come back, if they're reportable conditions that the lab has found, they would send that on to public health directly. And we'll talk a lot about ELR, electronic lab reporting, which is really a main conduit today from the labs to public health, main electronic conduit from labs to public health. And some work that's going on with reporting from healthcare providers to public health under the banner of electronic case reporting. Okay, Okay, Annie, it's yours.
Thank you. Our first charge was really to focus in on pregnancy status. Pregnancy status is something that is really critical for a number of reportable conditions, Zika being one of the most recent and prominent of those. And, clearly when you are having a pregnant woman, you really have two patients, and the impact on the fetus and the newborn infant is something that public health can help to prevent any adverse impact from these types of infections, as well as to help to diagnose what's happening in the pregnant woman as well as the infant. So unfortunately, at the present time, there's no standard way to capture pregnancy status and associated data in electronic medical records, and there's no existing consensus on the minimum public health data elements that are needed to actually capture the information about pregnancy. So our goal was to identify these priority elements, and we did. We managed to gain consensus among the public health community, the medical folks who we included in our deliberations, and also from others on which small number of elements we thought were essential to be able to capture. And those elements are available to you in a document that was circulated, which I hope all of you received. And we also included the proposed standards that could be used to capture the data and map it to existing documents. So while capturing pregnancy status in the EHR in a standardized way and transmitting it to public health electronically is where we want to go, this really isn't possible now. And so another way to capture it is to actually ask providers when they're ordering a test to supply a minimum amount of information for key conditions where pregnancy status is relevant. And so we are promoting ask on order entry for transmission via electronic laboratory reporting so that pregnancy status can be transmitted to public health in that way. This is a short-term recommendation or medium-term recommendation, which we hope to have implemented before the bridges between the electronic health record and public health are actually implemented and in production. We also recommend to publish these data standards in the ONC's Interoperability and Standards Advisory, and to, in response to the committee's input during our last meeting, we did we do recommend to explore ways for the individual to electronically self-report pregnancy status and other related data, and to potentially electronically capture that data, as Larry mentioned, into the provider's electronic health record. We're going to dive a little bit more into some details on some of these as we go through these slides too. So the next charge was to figure out how to transmit that information to public health. And the challenges here are that, as I mentioned, public health currently does not receive pregnancy data electronically in any consistent way or complete way. So we do have a really amazing amount of data coming to us via ELR, and that's been a really successful a lot of progress has been made in that over the last few years. In New York City, that is the primary way we receive data on many reportable conditions, but pregnancy data is often not included, can be included occasionally in data from commercial laboratories. And electronic case reporting is not in place yet. So pregnancy status is really needed, not just for follow-up of actual cases of Zika or other reportable diseases where it is important, but it's also important for us to capture it at the time of the test order to make sure that the appropriate tests are being ordered for a pregnant woman. The testing is very complicated, and we've identified a lot of disparities in who's getting tested at all, whether women are actually being identified as being at risk for Zika appropriately, and also for which tests are being ordered for any particular pregnant woman. So our recommendations are that we promote pregnancy status to be transmitted for Zika and other reportable conditions where pregnancy status is relevant. And I'll go into what those are a little bit later. But I also wanted to mention that we did add to include chronic reportable conditions. It's important in diseases such as HIV or as hepatitis C that the existence of pregnancy in a reportable disease that may have been diagnosed in the past is something that itself should be reported because it can have a potential impact on the infant or the fetus. And it enables public health to intervene to be sure that that infant is treated, vaccinated appropriately and in a timely fashion. In the short term, because other methods are not in place, we do recommend to expand the use of electronic laboratory reporting to transmit this critical information to public health for Zika and other reportable conditions. And while we do recommend ask on order entry as the preferred method to capture it, we, in the meantime, because that also requires some time and resources to develop and to make it widespread, we would like to promote the use of a specific prenatal test for Zika to indicate pregnancy status. And I will go into that a little bit more later, too. And then we recommend publishing these data standards in the ONC Interoperability Standards Advisory, and we encourage state and local jurisdictions to use their existing public health authority to require the transmission of pregnancy status. This has been done in some jurisdictions, but not in all. And to promote the use of the ONC's Interoperability Proving Ground as a place where information can be shared on public health interoperability projects and to enable labs, vendors, and others, and healthcare systems as well to share best practices and processes that work.
Thank you.
You're welcome.
Thanks, Annie. So moving on to clinical decision support. It's really important to integrate the guidelines into the workflow of the providers. And so this really was the heart of what we want to do with clinical decision support, and recognizing that the guidelines for emerging diseases are often changing rapidly. So whether it was some of the things that were learned around Ebola or the things that are being learned with Zika, to know that you can't just say that there's a guideline and we can publish it and we're done. But in fact, the guidelines themselves are changing, so whatever is done needs to recognize that dynamic state of things. And that the guidance doesn't come just from a single source. So often local health departments, for very good and important reasons, have guidance distinct from what's being issued by CDC. There may be local transmission that's important to be more sensitive to in some of the southern states that have mosquito populations than in a colder northern place. So they'll vary. There may be a high incidence of travelers coming in and out of a location, and public health needs to work with those differently because they represent a different population. So how do we work with these variations in guidance as well as the importance of it changing as well? And we have an example of as Annie was saying, that the lab tests to order are very specific, and that we unfortunately had examples of several hundred of the wrong lab tests being ordered, and so you get inconclusive results because of that, and getting good guidance to people because the window for testing can be really short right after exposure. So, that sort of summarizes the current challenges that we're facing. Most of the recommendations here recognize the emerging state of clinical decision support. So there are some demonstration projects that look at using clinical decision support working with public health. The RCKMS project in specific is one that we heard about. So looking for those as best practices emerge. To explore sharing CS implementations across providers. So we saw a lot of this with Ebola, and we're seeing it as well with Zika, that healthcare providers, based on the capabilities of their vendor, are sharing with other other healthcare providers that use that same technology and how to implement good decision support so that it actually helps detect the people who are at risk and doesn't interfere with the care for those who aren't. We're also looking to encourage clinical decision support to improve access to human-readable guidance. So the trigger might be in the EHR, but the action side might just be informational at this point. It may not be fully integrated into the EHR or fully implement the logic of the guidance, but at least make sure that the providers have current guidance for the patients at risk. We also looked at mechanisms for consumers to identify their own risk and to be able to then document what they found. So we know that individuals might be using apps to plan their travel or apps to manage their fertility status. And so as they use those apps, it would be great if those apps provided additional support that tied into the guidance that's available. And finally, to explore use of open APIs. We heard about CVS hooks as one example of that, using FHIR, other technologies that are in play that could support clinical decision support. We also had a fourth charge, electronic case reporting, and the challenges are that there aren't good standards in place for a connection between public health and providers and to create the two-way connection that's really needed. And we also saw an example of a bright spot where Digital Bridge is a project that's really convened a lot of the stakeholders to come together to work collectively on addressing this problem. So a big piece here on the case reporting is, again, to use the standards that have already been put forward to leverage the work on the existing projects like Digital Bridge, to explore use of new and maturing standards, because we are in an environment that really is changing a lot. 8 years ago, we had very low adoption of technology. Today, we have very high adoption of technology. So there is a technology base there, although it may be very diverse, and we know there are some issues of getting convergence around standards and really moving information. But we see this as really an area where the standards have matured and are continuing to mature, and new ones like FHIR are getting a lot of traction and becoming a method that we could use to better tie the information together. And again, looking to promote existing mechanisms to share best practices. So the Interoperability Proving Ground is a place for projects to publicize their work and to bring people into some of the practices that are already in place. So how did we get here? So we began our work in December. We had a taste of that last year. Jim Daniels did a presentation to this group in the fall, outlining some of the work that had been done, and that led to the formation of the task force. We had an in-person hearing in February with panels representing some of the breadth of stakeholders, and then we dove in additionally into some other areas, specifically around case reporting, the pregnancy registry, Zika pregnancy registry. We did a lot of work around the data elements, looking to get good engagement and a lot of vetting, and recognizing that's really an ongoing process, but we feel like we've got a very good foundation here. Look further at clinical decision support, the continuing importance of ELR, electronic lab reporting, and finally, we tried to incorporate the feedback we got last month on things we ought to be acting on.
Okay. So just a bit of background, and I know some of the committee members have heard this before, but there were people who probably didn't, so I'm going to remind all of you about this. So for the first charge, the reasons that it's important to capture pregnancy status for public health. So multiple infectious diseases are important in pregnancy, and those include Zika, hepatitis B, syphilis, HIV, varicella, listeria, other diseases as well, such as diabetes clearly, and this could be extended to opioid dependence, all kinds of chronic conditions. We're focusing in on reportable infectious diseases now, but we're hoping that this work would help with management of many other conditions as well, and identifying pregnant women and enabling sharing of information that could help to prevent and alert clinicians as well as public health to the pregnancy. Lab diagnosed cases are reported via electronic laboratory reporting or via other means to public health, but the volume can be very, very high. So identifying those in which a woman might be pregnant is critical, because when we investigate reports of infectious diseases, we have limited resources, and we need to prioritize those where it's most important. In the case of a pregnant woman, it's important with Zika. It's important because not only do you want to enable the woman to get accurate, the best testing she can get, the best treatment she can get, the best monitoring she can get, but also to be able to identify when that infant is born, to make sure that that infant gets tested appropriately. So the timing is really critical. For infants, they need to be tested ideally within the first 2 days of life in order to meet a case definition for Zika and in order to have the maximal probability of being able to detect the antibody to Zika, the IgM antibody. So it's important to identify pregnant women, and it's important to know when they're supposed to deliver, and it's important for public health to be notified at the time of delivery, but we are not always notified, so that we can appropriately test that infant and know for infants who are affected, who are microcephalic, or even for those who are not obviously affected at the time of birth, whether they truly were infected, whether they truly have congenital Zika infection. So we need to prioritize investigations and know who's pregnant. I mentioned about the follow-up of the infants, but the other reason it's important is to get the appropriate guidance to the providers regarding test interpretation and case management. So these tests are very, very difficult to interpret. We have we've spent over a year dealing with this in the New York City Department of Health, and even amongst ourselves who've been dealing with it for 15 months, we often have questions about what the tests mean. We answer many questions from providers about what the test results mean. So we like to be able to offer guidance, especially to providers who are managing pregnant women, to help them understand what those test results mean and know if any additional testing needs to be done. So for the pregnancy data elements, we did develop these priority data elements, and if you're interested, please refer to the Excel spreadsheet, which was put together by one of our task force members, who was really wonderful, and we've tried to specify the mappings in many documents that are used to transmit data as well. Pardon me if I speak technically incorrectly, because I'm just a public health person, so that would be why, but I'll do my best. We vetted these recommendations concurrently through the health IT developer community, through public health, and through healthcare providers, and we recommended that these data elements be included in the ISA. So this is a list of the data elements that were identified and on which a remarkable degree of consensus was gained. The ones in green are the ones that we considered to be the most important. They include pregnancy status, the date of the pregnancy status, because pregnancy changes through time, and the estimated delivery date, which is important for the reason I mentioned. We need to know when that infant is likely to be born. Many infants don't come to attention soon enough, and then the opportunity to diagnose them is unfortunately not there. We may never know whether those affected infants ever really truly have Zika or something else. Also, gestational age and date of the gestational age, which is really an alternative to the estimated date of delivery, and then the outcome. And the reason the outcome is important is, again, to know whether a patient who has been being followed actually did deliver. Again, the reason being primarily to make sure the infant, whether it be Zika hepatitis B, or something else receive appropriate treatment, which often is to actually prevent infection or the consequences of infection in that infant. And then there is another element which we wanted to include, which is the multiplicity of fetuses, so whether it was a twin, triplet, et cetera, gestation, just to know if we expect to have multiple outcomes. So one of the comments from the committee last time was to explore how to focus more on the individual as opposed to the provider or public health. And so we did explore an application which is called My Health Finder. I'm sure there are others like it, but this one looked really interesting. It was created by the Department of Health and Human Services, and it offers a sort of tailored guidance, an interactive tool for people to put in what questions they have, who they are. It might be, I'm pregnant, where can I travel? And this tool provides that type of recommendation back to them in an interactive way. It uses an API, and it can be rebranded. It does not retain any of the data that's sent into it by the patient, the person who's not a patient yet, and it doesn't deliver the information to any provider as well. Because of the API, it can be integrated into any other website, a health department website, a provider website, and it actually can be customized too. So CVS took it and put it up on their website. It can be reprogrammed to provide whatever customized information is needed for that particular site or that the person might want to know. So we also, as mentioned before, would like to explore ways for the individual to communicate their information to their provider electronically so that it could be captured that way as well and perhaps even followed along that way. Okay, just as a reminder, the Public Health Authority for receiving this type of information, the health and sanitary codes at the state and local levels are the ones that authorize public health to receive and investigate reportable diseases. We receive that information via electronic laboratory reporting, by case reporting, which can be by phone, by fax, by paper, by web-based data entry screens, and ideally in the future through electronic case reporting. We do case and contact investigation and management of many of these diseases, and then we use the data to detect outbreaks and unusual manifestations of disease, and all of these we have the authority to detect, to be reported to us with identifiable information as well as to investigate. HIPAA allows for the disclosure of this data to public health, and pregnancy status may be required to be submitted with a case report when it's relevant. And this is what we do in New York City. We require that it is actually in our health code that it be reported. There's a new fact sheet from ONC, not quite as new now, but it's really great, and it documents the permitted uses and disclosures, exchange of information for public health. So I encourage you all to take a look at that. So for sharing data on pregnancy, from hearing from the laboratories, from public health departments, we really landed on ask at order entry as being the best short-term option for capturing this information and sending it to public health via ELR. The ask on order entry does take some work for labs to implement. It takes resources. They have to modify their interfaces. So it's not in place yet among all laboratories, and it's not transmitting this information in a consistent or complete way. So it will take time even for ask on order entry to be fully implemented and to really increase the number of times pregnancy status is transmitted. But it is preferred in some ways because it could transmit not only the fact of pregnancy, but it could also transmit some of the other relevant data, such as the date of delivery, et cetera. In the meantime, because there is going to be time that will be taken to implement it, we would strongly recommend also the use of a prenatal test type for a Zika test that would indicate that the woman is pregnant, and that can be mapped into the ELR message. And we would like to recommend that it would be mapped in the same way across laboratories so that public health can receive it, know how it's going to arrive, and process it into their surveillance systems automatically. That would be the best way for it to be done. And we have some suggestions about that we haven't finalized yet, but in terms of where it should be mapped to in the HL7 message. And then long-term electronic case reporting is really the best way to go and will deliver the most amount of needed information to public health once it's set up.
So the intention here is not that we work ourselves through the logic here, but just a reminder that there is complex logic for the guidance, and that, in fact, this logic has been developed as part of the ongoing work to support managing Zika. And we also have a cascade of activities here that takes us through initially defining what the guidance is, to creating it in a semi-structured way, to structuring it, to making it fully electronic. And we recognize this is an evolution, an ongoing activity with a lot of work. We identified some bright spots where this is currently happening, mostly built around vendors who have CDS capability, and then healthcare providers would then implement that locally. We're also seeing examples of suppliers of clinical guidance, the sort of reference sources that might be embedded in the EHR for direct lookup from inside the EHR, and that those systems are taking on the complex work of bringing the algorithms into their offerings. So it's not just literature search, but it's actually here's guidance in a form that supports decision support and can walk individual through those screens. And clearly embedding that in the workflow for the right person is really important as well. You don't want to ask someone a question that they have no way of getting the answer for, or completely interrupts the work that they're doing. And we're also seeing pilot projects underway that look to make this much more machinable, work that's been done in other areas to support public health. And so there's a lot to build on here that could be used to much more fully automate this. So this is a reminder of how this happens. So in this case, public health is acting as the supplier of the guidelines. Those then go to developers who can embed them in the technology, and developers here is being used really broadly. So the developers might be vendors of technology. They might be healthcare providers who are creating logic inside their own application. They might be third parties that are creating executable environments and then putting content into them. And then they go to healthcare providers that then integrate into the workflow. I'm realizing, looking at this provider slide, I should have emphasized way back in the original diagram that we're using providers here as the generic term. So this could be, a single physician practice somewhere. It could be a large, multi-setting, multi-site health system, or almost any flavor in between. So really looking broadly at where healthcare is provided. And that workflow integration is really important for the clinical decision support to work. So some of the additional background here around looking to identify individuals at risk, to ensure that the appropriate tests are ordered, that the triggers point to the specific actions that are needed, and we uncovered lots of examples of inappropriate tests being ordered or really very low rates of reporting pregnancy. So it's a combination here of having good triggers in the EHR and then collecting that information and using the CDS to move that forward. And some examples that we've seen of best practices that in some way are very low tech, but are very helpful. So public health has started using consistent URLs for their guidance on a specific disease. So if you need to get the current version of that, you just go to the same website, and the website will be updated. They don't change the URL, like, with the date of the update, which then would require that you have a new link every time you want to use it. And also, many of those websites support RSS, so you could get automated feeds of when the information changes. So they're, in some ways, very primitive tools, but also very usable. And a reminder about, for clinical decision support, you want to reach someone through the right channel with the right information about the right things that they need to do in a format they can act on. It goes to the right person, and it goes to them at the time they're going to be able to take an action. So really focus on making this usable and not just create alert fatigue or information overload. We spent some time delving into what's happening with CDS Hooks, which is open source project, and it really has two critical aspects here. One is to embed the triggers in the EHR using the native clinical decision support capabilities of the electronic health record tools to trigger starting the hook. So that's sort of like the hook sign, that's the beginning side, and then it calls web services to provide the actual clinical decision support. So call out from the EHR to web services that could be hosted locally or could be hosted out there in the world of the web. And then protocols for how you would then access the data back in the EHR. So it's working within the SMART framework that was developed in the past, and then using FHIR as a way to get data into that application. So it's a model that's being pursued. The Argonaut project has chosen clinical decision support as an area that they're going to be working on this year, moving forward the use of FHIR. So we expect to see new work coming in how all of this comes together. And looking to make recommendations to continue exploring use of open APIs, and also to look at clinical decision support that supports consumers. So Annie mentioned that My Health Finder is not just a website, but also can be accessed through APIs. And so that's an example of where you might use APIs to access guidance without it being very complex embedding of a logic engine, but just a way to get to the guidance. So this is a reiteration of our recommendations around building on the demonstration projects, exploring sharing of CDS implementations across provider locations, so really taking advantage of a local bright spot, whether it's geographically local or vendor local. There are also other demonstration projects coming out of ARC, for example, the CDS Connect project that's building a web repository that could be another vehicle for sharing this information. In short term, to encourage use of clinical decision support for access to human guidance, mechanisms to support consumers to assess their own risks. You could avoid a problem by looking at where you travel to, what you do to avoid mosquito bites and things like that. So could be some very specific actionable things, and continue to explore use of APIs. And finally, electronic case reporting. So this is an area where really robust communication between healthcare providers and public health could be a really important step forward, but it's an area that's relatively recently getting renewed attention to directly build this into the systems and to improve use of healthcare as a source of information for population management, for detecting outbreaks, and for working with the local needs. We talked about the difference between EICR and ECR. So ECR is broadly electronic case reporting to generate the information and support the exchange. And EICR refers to some specific data sets and specific document types. And so we've tried to keep those clean in most of what we talked about, but I noticed going through the slides there might be one or two places we still need to edit that. Our intention really here is to focus on the process of electronic case reporting and make that better, and to make sure that the EICR, the document, includes the standards that we've put forward for reporting pregnancy. I've covered a lot of this before, so building on the standards to use those as part of any work on case reporting and the EICR documents, that we build on the work of Digital Bridge, that we look at RCKMS and other projects that are looking to formalize the knowledge and making it accessible, and that we look at bidirectional data exchange as really a key piece. We didn't show that in our initial slides. We really focused on this initial reporting to public health, but clearly there's a lot of follow-up activity, and anything that can be done to streamline that and build on the information that's already been sent would be really helpful. Okay, we'll give you a very quick recap on these, and then we'll open up for discussion.
This is really just a summary slide with the actual recommendations that we've already reviewed. So I don't think I will dwell on it. The only thing I will add, which as I was sitting here I remembered, is that we did hear at the last virtual meeting that we had about the concern about linking the pediatric community in with all of what's going on with Zika and other conditions that can affect the infant. I don't know where that went forward. I'm going to go back. So we did hear about some best practices where data reflecting the mother's pregnancy status and tests that were done during pregnancy for Zika and for other conditions are presented in the newborn's record, and I do want to highlight that as a best practice. I think that one of the things we've observed in public health in managing a lot of these pregnant woman-infant pairs is that the infant, when delivered, there's no information necessarily available to the caregivers for the infant about the mother's status. And so presenting that front and center at the time when the infant is born is really critical, and some systems do that, gather the information and put it right in front of the pediatrician's face. That is an important thing to do, and I would like to highlight that. I do think that that's something that we should also be calling out as a best practice. Okay, so this is really just a rehash, and this, again, sending and sharing pregnancy status with public health. This will fall on laboratories in the short term, and we're hoping that these recommendations will be implemented by laboratories and by systems who are using the interface with the laboratory, because it's really critical, especially even for this upcoming season, that this be implemented as widely as possible. Currently in New York City, we're getting a really small proportion of cases of Zika where in pregnant women, we've looked at our data where pregnancy status is actually indicated. So again, I won't dwell on these because we've already gone over them.
So since I just talked about clinical decision support and electronic case reporting, I'll use the time for our discussion.
Mm-hmm.
That's it. Wonderful. Thanks again. Thanks again to the task force. You can see there's a lot of details that's required in order to make seemingly a simple fact about an individual known to the people and machines that it needs to know it in order to improve our care and avoid things falling through the cracks. One of my favorite recommendations they had was the ability to have self-reporting. It reminds me of the attending case rounds in the inpatient setting where the house staff, interns, and residents present to the attending. And normally the interns and residents are debating about whether this person has a risk for this or what it has based on all the lab and imaging. And then the attending would say, Have you asked the patient? And that would sort of bring a pause to the discussion. So it's wonderful that people are allowed to, that you're recommending that we have a way to incorporate when a person wants to self-report that they're pregnant. So thank you. And the first card I saw was Arian. You want to go?
This is more by way of editorial. So first of all, thank the task force for incredibly detailed and thoughtful recommendations. When David McCauley and I were co-chairing the API task force, one of the points that we made about driving to a common, ubiquitous set of APIs and content standards is that it enables more general capabilities, and there's a tendency in public health to, in some sense, fight the last war, and in other senses to invent new and bespoke standards for particular purposes. To the extent that we can double down on the progress we've made in Smart on Fire, in enabling API access, in areas like electronic case reporting, or in clinical decision support hooks, we're able to get more leverage out of HIT vendor system development and not force them to adopt and develop more specific standards for this thing and that thing and the other thing. So clinical decision support hooks is a good example of this. The ability of, through Smart on Fire and the work that we're doing, the Argonaut project, to treat the EHR more like the iPhone and launch apps, I think is a good template for electronic case reporting. So more a plea to, in the public health community, double down on the trajectory that we're already making with HIT vendor systems, and make sure that we can do the more general work there. None of that, obviously, mitigates against the need in specific outbreaks to get to the level of specificity that the two of you have noted and that Paul just noted, that you need to get down to more granular and more specific levels. But to the extent that you can do that on a more generalized platform, you're going to have a lot more tools and flexibility in public health. Thank you.
Thanks, Aaron.
Yeah, Aaron, thank you for the comments. We really tried to balance what's actionable today, so the focus on ELR was this is in place today, a large volume of information is going through there. If we can improve the percent of test results with pregnancy status, that would be a big step forward in the short term. We had a lot of discussion about, had we done enough due diligence, if you will, at all of the various options for implementing things to make a stronger recommendation on new technologies than we are making here. But I feel like there really is a huge opportunity here to leap into the emerging technologies and really give us a more powerful base to build on. So more personal editorial statement, as it were.
Thank you.
I'd like to see that get a lot of traction.
Thank you. John?
I got a raft of thank yous that I'll say. Ann and Larry, thank you. This is incredibly important stuff, and Zika is the match, right? But it's a big pile of kindling that it lights up. So I appreciate you all grappling with this and pulling your colleagues together to do it. Would love to also acknowledge the good Dr. Richards here with us today, and his team. Of course, you know how much we love Sanjeev Tandon, but we love everybody there too. So thank you for working with us in the task force, and kind of trying to think through these recommendations. So thank you. And of course, my beloved team at ONC, Jim, Lee, everybody else, thank you. I appreciate the effort that you all put into this and kind of getting these recommendations in front of us. There's just one thing in particular I wanted to ask about. When you hit that first set of recommendations and said we don't really have standards for capturing pregnancy status, I thought to myself, oh dear Lord, you're kidding. I can talk about the encounter with Cal, repeat in ICD-10, but I don't have surely we've got standards, but did you mean to say and said that we're not using them, or could you drill down on that a little bit?
Yeah, so maybe I'll jump in for some on the tech side, and Annie could fill in some more color commentary. So there is a spreadsheet that was circulated to the committee that actually identifies the specific standards, John. And what we found is, depending on context, there was a lot of variability. So if you're describing a lab result that indicates pregnancy, you would code that one way. If you're using ICD 9 or 10 coding for a diagnosis, you might say someone's pregnant. Right, it doesn't sort of get us to the level of granularity that we were looking for. So,
or consistency, rather than granularity, right. It's consistency
right.
for our purposes. Okay,
right. So what we did was to say, this is what's out there today, what actually is in use, and can we make some recommendations on moving forward with narrowing those? And our suggestion was to bring that into the ISA process, so the Interoperability Standards Advisory process, and specifically address the way in which pregnancy is coded and where we can move ahead the consensus, if you will, to get better convergence. A lot of people are going, yes, we need to converge, but as soon as you get into let's converge, the conversation diverges. So it needs more
power of standards,
right? It needs more help and more effort to get that convergence forward. And I think the ISA actually has been a really good vehicle for surfacing the options and beginning to narrow them and give people the decision logic around why you would choose one approach over another. And so I think there is some positive motion to do that, but yes, there's continuing work to be done.
All right, Mr. Posnack, you owe the good doctor a drink. Okay, good.
Thank you. Gail?
I guess I would just like to add that we specifically did not want to stipulate or add any work to the providers need to document in a particular way or to dictate how the data should be collected, but we wanted to improve the ability of EHRs to capture the data so that it could be shared for women of childbearing age, including not pregnant, not pregnant, to the extent possible. Obviously, for every woman, for every encounter, you're not going to be able to necessarily document that. So unknown is an option for somebody who comes in with a sprained ankle, 15-year-old. That does not necessarily need to have an explicit pregnancy documented. But for it to be able to be captured in a more standardized fashion so that it's expected to be there and be able to be at least calculated and transmitted.
Thank you. Gail?
Thank you very much. And first I want to thank the task force for their recommendations and their report and their hard work on this. Having run an OB/GYN very large practice for many years, I can tell you having some standards in really in determining pregnancy and reporting it, making sure that the records are consistent. If you've ever changed vendors and you have had one standard versus another standard and you're trying to determine age of gestation, estimated delivery date, those kinds of things, it's very, very difficult. So that, for the practicing physician, that would be tremendous. Also, coming from Florida, I can tell you Zika is, we are probably the epicenter of what is going on with Zika, at least in this country, and with Miami having had several outbreaks, and the need to really address Zika. We're putting $80 million currently in our state budget just to address the Zika situation. But I do want to bring up something, and I hope that the task force will have a little conversation from the political side of this and the political perspective of it and the privacy concerns that are there when you come to pregnancy and the potential termination of pregnancy. We have various state laws, and states vary state by state as to what the level of consent necessary to have any reporting of termination of pregnancy, or when you're talking about the gestational age of the fetus, and all of a sudden there is none, that's a termination of pregnancy. So you have a lot of people who will be very concerned that there may be privacy concerns about abortion here. So as you go forward with your discussion, please have that discussion and also the understanding that many states have very specific state privacy laws that must be considered when you are going to be transmitting information without specific consent, whether that is coming from the laboratory or whether that is coming from the provider's, the physician's office. So those are things that must also be considered as you move forward with these recommendations. Thank you.
So thank you for that. I actually think that's a very important point, and I do think it's one we should grapple with. I very much agree with that, and thank you for bringing it up. For reportable disease reporting, I believe that at least in the New York City Health Code, which is what I can speak to, but we should explore how those laws that you're mentioning, the privacy laws, impact the transmission of reportable disease data relative to pregnancy or termination of pregnancy. I believe under the New York City Health Code that transmission of any data relevant to that condition can be transmitted and obviously needs to be protected in the same way any confidential medical information would be protected. But I do think it's a really valid point that we need to explore as to how those privacy laws might interact with that other law, which is a local law, and other state laws which enable the transmission of confidential patient information to public health.
Follow up on that, please. Follow up. Yes, I would just like to say that there are specific consents necessary in order to transmit. So, and it varies state to state, as it does with HIV reporting. So, although that is a reportable condition, you require consent at various levels. So that needs to be considered as you move forward.
So, Gail, thank you. Just a reminder that there also is an ONC fact sheet that's linked to from the material. I guess if you have the actual slides, you can get to it. We could get the URL added as well to try to frame this issue, because we did recognize that there are privacy concerns as well as public health law that allows for the sharing of this information and clearly requires protection of it on the receiving side.
I'm not aware of consent being required for reporting of reportable conditions, but I will certainly look into it further, and for the associated data. I'm not aware of that. I think the consent for the HIV test is obtained at the time of the testing, but not for the transmission of the data.
Yes, I do not believe that pregnancy is a reportable condition.
I think it's an important issue that Gail brought up, and I think it's worth going through your recommendations to see how to incorporate that in light of her issue that she's raised, and see if there's a way. I'm sort of sensitive to the fact that we'd like to approve this, but I think we want to make sure that these considerations are at least either incorporated or at least described, so that the reader would be aware of these kinds of considerations.
Thank you, Paul.
Thanks, Gail.
Thank you, Gail.
Aaron.
Thank you. So first of all, great work. I think this is incredibly important. Spending over a decade in the Dallas-Fort Worth area as a CIO, I saw firsthand, ground zero when Ebola broke out, and the left-hand, right-hand syndrome that occurred because we had not collected the appropriate data up front upon admission. And credit to the government, CDC, and others stepping in and giving recommendations after the fact. But then it was, too late. We were literally spending nights putting up tarps in the units and the children's wards, worried that we were going to have an outbreak in the city. So I wanted to stress that I feel that this is incredibly important to get ahead of a potential issue. It's very important to standardize this information in general and look at it. I do also want to touch upon what Gail said. I think it's important, especially from a pediatric sense, that consent is considered, especially when it comes to pregnancy status. That was something we grasped and dealt with even at a state level from an HIE perspective. How do we share data? How do we do this with consent, especially with minors? And then what what does that look like? I don't know the details of specificity to be able to answer your question, Gail, but I do think there's some other aspects of that should be considered. However, the importance of collecting this data in a standardized way, I cannot stress enough. After seeing it firsthand, we must do something and start aggregating this in a very meaningful way.
Thank you. Andy.
Thank you. First of all, my thanks. I was on the task force. My thanks to the chairpersons because it was, as usual, a fairly large herd of cats, and they did a great job. As the pediatric infectious disease doctor on the task force, I was very gratified by the outcome of the work. I would say that we did talk about privacy concerns in general, and the fact is that, and we also talked about, to Arian's point, trying to make the recommendations something that were not sort of Zika contingent, but rather generalizable, so that the next Zika that comes along, this would be a useful set of recommendations. So we did grapple with that. Just for everybody, again, for the clarification of this particular last discussion, Zika is the reportable condition, just like varicella is the reportable condition. Pregnancy is a patient status that's relevant to the care of the patient and the care, in the case of a pregnant person, the infant after it's born. So I think the context for understanding the privacy concerns has to be taken in that order. We're worried about Zika if you're pregnant and you're going to have a baby. That has an impact on the baby, and it's got an impact on what's done for the mother and what's done for the infant beyond that.
Thank you. Ann. Sorry, I didn't see Leslie's popped up. Thank you.
Thank you, Leslie Kelly Hall. I just really admire the work that you're doing in getting ahead of it, as the earlier folks have indicated. One of the ideas, though, around the standardized assessment tool that could be formed as you go forward is to make sure that assessment tool is also for self-assessment, so that patients can participate and be educated along the way, self-assessed, and communicate both with their providers and public health. In times of crisis, we often look to government to help us, and the CDC does an amazing job. Let's provide a way for patients to help in this process, to understand their conditions, to seek treatment as appropriate, and help for the babies after the fact. Thank you.
Yes. Oh, go ahead. I thank you so much for that point. I think that's a really critical and important point. I wanted to mention something that came up during our deliberations that wasn't included in the slides, which is we are in New York City, we're actually using we're printing a paper card that's sort of like an immunization card for the mother to be able to carry around with her, so that she would be able to present it to whatever provider she goes to with her Zika, the information about her Zika status, the tests, because the tests, if she goes to somebody else, they may not know what her test results are, and then also to present to the pediatrician once she has the baby, so that the pediatrician will be able to look at that information and add information about the infants and infants testing. This a paper solution to a problem where information is not flowing well from obstetricians and hospitals to pediatric providers. But to make that in an electronic form would also be a great idea, and to make that available to the patient so that the person herself could have access to that information, as well as to provide additional information to the providers, I think is a great idea.
Good, thanks. Ann?
So I reviewed this with our internal experts, and I just wanted to pass along their commendation and applause for your task force works. It was really a nice piece of work. I would like to add on, just to support a little bit of Gail's comments, anything our software developers can do to help us appropriately capture this information in a uniform way, I would highly recommend. And if they can help us get from the point of capture, whether it's the provider capturing it or the patient capturing it, and bring that into orders so they could review, edit, and then pass along. They have to capture so much of this information. It's becoming quite a burden. So I would like to see them encouraged to help us use software to solve that problem. But thank y'all.
Yes, it was certainly our intent with the focus on standards that would allow for reuse. So once you know it, the process of moving that data forward could be streamlined.
Thanks, Ann. Lorraine.
Thank you. Thank you for a phenomenal presentation, and welcome, Dr. Fleming. At CMS, we not only have long titles, but we also work a lot of tables. And so I have a couple of different comments to share with you. One is the presentation was really meaningful to me because I have a personal friend who was in Florida who had been bitten by a mosquito. And so she had the risk of having Zika, and her physician burst into tears when the test was being taken. So it's resonated with me a lot. So thank you for the presentation. One of the things that I wondered if you had looked at, and I know ONC has looked at something that HL7 is working on, which is the personal health record system functional model, which has as part of it public health reporting, which is connected to the electronic health record. And the public health reporting would go both to the electronic health record as well as to public health agencies. And that would be one of the ways that Zika could be reported, both from the individual to the physicians and to public health agencies. The ballot has just gone up, and the deadline is tomorrow for commenting on it. And then it'll be available for review in May. So if you would take a look at that, I think it might meet some of your needs because that very issue is being addressed there. So I wanted to bring that to everybody's attention. And ONC, I know, knows about the PHR model and how it's connected. And then the other item, and this is part of the alternative payment models that the Center for Medicare and Medicaid Innovation has, talking about the whole data issue of pregnancy. There's a maternity action collaborative that they're working on, and one of the questions they have too is what's the indicator that they capture? And so that might be something, and I don't know if anybody in the room has been working on it, looking at any of the maternity action collaborative models that are around the country, but one of the questions is how do you capture pregnancy, and looking at who is in those models and what patients are they capturing, and whether they're even looking at the Zika patients or the potential for that. So that might be something to look at too.
Yeah, thank you, Lorraine. We've had lots of conversations across many of the pieces of HHS and with HL7, and those two specifics did not come up in our discussions. So thank you very much for bringing those forward.
Good, thank you. Floyd.
So first of all, as a member of the task force, I want to thank the chairs for their comprehensiveness and for keeping us on task, which was not always easy, and especially for the attention and care about clinician workflow, because that was part of the discussion all the way along, and thinking about things like pregnancy specific tests. So you just order the right test that actually indicates the patient's already pregnant. And aspirin order entry, which we didn't go into here or specifically in the task force, that an inference engine within the software could help to pre-fill, and the doctor or could accept or not accept that answer. So there are mechanisms that can help that, and that was clear attention to workflow and also to the consumer workflow, the consumer finding the information and sending it to the doctor because they know, they're aware. I think it's important to, Larry, in answering a comment, mentioned the spreadsheet. There is an accompanying spreadsheet, so some of the comments, I think, Paul, when you first said there's a lot of detail here, a lot of the detail that explains the specific elements within the slides is in that spreadsheet. So the group did look at the details. One of the details that may need a little more definition is if you're going to include this for any chronic reportable disease, then identifying what they are to make it easier for vendors to be able to connect the two. And the last comment I would make is about CDS. There actually are current prototype pilots, not necessarily in production yet, going on in HL7 with CDS hooks to try to use it specifically for Zika virus and also other emerging hazards. And so there's really good work going on this year, and you'll see more of that in HL7 standards for the September ballot cycle. Thanks.
Thanks, Floyd. And someone on the phone.
We did have Troy Siegenthaler, but he took his hand down.
Okay.
But Paul Eggerman also has a comment.
Paul?
Yes, this is Paul Aikman, and I want to add to everybody else's comments. This is excellent work, so I want to thank the presenters. My question is about privacy. Basically, pregnancy status is not a legally required reportable item right now, I think, in most states. In fact, I'm not aware of any state where pregnancy status is required to be reported to public health agencies, and I can think of a lot of situations where the patient wants to keep that information private. For example, if the patient is a teenager, there may be special privacy considerations. And so how did privacy considerations impact your work, and is there a need for special privacy rules around this information?
So Paul, we did look to bring privacy considerations into the work, really focusing on the reportable pieces, and then really looking to make sure there were mechanisms that we could report pregnancy. We know it's a very charged area for privacy. There's been some discussion here already about recognizing that. And I'm also hearing a suggestion that we probably should explicitly include that in our materials as we get our letter of transmission together. So thank you for bringing that back up.
Thank you.
Thanks, Paul. Jen.
Thank you. I wanted to share a couple of comments. One was from a provider's perspective, or maybe I should say provider workflow perspective. I just want to, first of all, double down on what Arian said at the very beginning, which is to the extent that we're utilizing what's already been built out there in order to capture the new data, that'll make a big deal in terms of the adoption and usage. So I just want to double down on that comment. I know that that's the direction this work group went down, so I just want to applaud you for that and commend you for thinking about it in those terms, knowing that that's really what's going to help drive adoption beyond just great sort of software that comes out of these committees in general. So I really appreciate that kind of outlook. I'd like to make two other comments, really around the consumer. One of them is we've, in the course of this discussion, a lot of it's focused on clinicians being able to capture that information for related to the pregnancy that's important in the case of public health, in the case of care of that patient. And one of the things we realize, of course, is that the data the patient provides may or may not be accurate, may not be complete. Me and my wife, we just had a baby a couple of months ago, and we almost learned that the hard way, that even somebody who's actually a medical professional may forget to share information that is extremely relevant to the pregnancy at that moment, because pregnancy itself is such an ordeal that it can actually subtract from your faculties to be able to share that information to your provider. So we saved our kid by sort of the skin of our teeth, because I happened to remember something that my medical doctor wife completely forgot because she was so exhausted. So that just underscores that interoperability has to be a big part of the data capture. You have to be able to get data from places where the patient themselves may not remember they have had data. And that leads me to this, my real point, which is unfortunately sort of a half-baked, off-the-wall comment, but it's probably important here, particularly to our federal partners, if not as much so to your exact reports, which is when you think about the example you used today, and I know there's a broader case of examples that don't require travel as a key component. Zika is obviously a very travel-related sort of issue. But for those class of infectious diseases for which travel is actually a big component, or other types of issues for which travel is a component, nobody really travels outside the U.S., outside of people who work for the CDC, travel outside the U.S. thinking about the next infectious disease that they may contract. On the other hand, when they do travel, they do want to know that they're going to have a safe and successful and fun journey or whatever that case is, and they have to start making calls to various organizations to ensure, that their credit cards will work when they get there, that the U.S. Embassy knows that they're going to be available for them if they get there and they get robbed or mugged or whatever the case. So there's this list of things that, at least when you're traveling abroad, you think about, to which notify my doctor that I'm traveling sometimes occurs, sometimes does not. Let me know what the CDC guidelines are for that place I'm traveling to. Sometimes occurs, sometimes does not. And I think it maybe just be time for, again, this may be more addressed maybe to federal partners than to this specific work group. But it may be time for us to start thinking about, well, is there a way that we can put into the consumer's sort of jobs to be done workflow, not the EHR workflow, not the medical workflow, not the healthcare workflow. But I'm a traveler, or I'm about to be a traveler. I want to be able to share data with organizations that will help me and help have a safe and successful journey who I might or might not remember to share with. There's no technology reason why we cannot do that today. I think it's a matter of figuring out where the dots are and connecting them. But that's something to, I think, seriously think about as we come out of this work group, among others, that suggests that we should be thinking about the consumer and the total type of thing that they want to do, including but not limited to healthcare. And I think we have an opportunity to interoperate at a level that transcends, a specific case, or specific sort of public health type of use case. So I'll leave it at that.
So a couple of comments back. So we actually did talk about travel as an obvious risk factor for Zika. And in fact, talked about that when people are traveling, that they often, from lots of sources, get reminders about immunizations that they might want to get and vaccinations they should get before they travel. But it doesn't always extend to emerging diseases and risks like this. And so there may, in fact, be hooks within the existing information flow around travel, apps people use to track their travel, websites people use to track their travel. The CDC website does have an option for I'm traveling. Where are there hotspots in the world I should be aware of, but you need to think to go there. So to start to push that out into the normal consumer workflow would be a really good thing.
The MyHealth software that we saw did hook into the CDC website. There is a place where I think you can indicate travel, and it will take you to, through a number of clicks to the CDC website that gives more information about that. And that's something that I think could be built out. There's also an I'm pregnant piece of that software. So obviously you'd like to get the recommendation not to travel. Unfortunately for women in Florida, they can't not travel to Florida, people who live in Florida. But for those who are planning travel to areas where whatever infectious pathogen is circulating, having easy access to that information and the most current information would be very, very helpful. And it would be great if more people used it. But I think bundling it together with other kinds of health concerns for the public is probably the best way to do it.
I also think it's probably a good place where we had some discussion about, in some cases the geography is pretty broad. The actual outbreaks in Florida and in Texas are all very geographically limited. So you want to actually know, did you travel in this neighborhood? Did you travel in this, pretty tightly constrained area? And so knowing that is often tough and requires the right level of specificity to not spin up a lot of anxiety that's not appropriate, but also to be able to direct it where there is specific risk.
Well, speaking of public health and the CDC, Chesley, did you have a comment, question?
Thank you. I had a couple of comments. One, I wanted to say for CDC that we're deeply appreciative to the task force, particularly the leadership of the co-chairs, the support we got from ONC, particularly Jim Daniels, and the members of the task force. This was an urgent issue that needed to be addressed, and you did it in a timely way, although as we talk about it, it's exceedingly complex, and there are issues that still have to be addressed. The second thing I would say is that I think there's a recognition that while CDC plays a very important role at a national level, global level in public health, the rubber meets the road at the local and state level. That's where the work is really being done on a daily basis. One of the things that we're trying to do at CDC is to find ways that we can support local and state health departments to work more as one public health as opposed to working in individual silos. So the work of Digital Bridge around electronic case reporting has been critical in trying to move forward as a united sort of public health and work with vendors and health systems. And I'm glad that that was also highlighted in the recommendations. Around clinical decision support, I think one of the things that CDC can do, and as Dr. Fine said, our guidelines often have to be modified or different parts emphasized at a local level. But one of the things that CDC can do in the guideline production we have is try to do more to make those guidelines more easily ingestible into decision support. So we've got groups within the agency now working, and we've met with HL7 and with others to think about how do we get our part of it done in a way so it's easier as a handoff. And again, I appreciate that in your recommendations you highlight some of the work in clinical decision support. And the final thing I'll say is, in terms of the recommendations here, these are really important for us. They help us think about what policy we need to do in collaboration with ONC, but also how we support both with financial support and other guidances to state and local health departments. These recommendations really help us in thinking about how to do that better. So thank you very much.
Thank you. Floyd.
Thank you. I just wanted to follow up on the travel question. So as the chairs noted in the task force, we did talk about that, and I think they were referring to the CDC website that folks with gray hair will remember as the yellow book that they used to publish every year, but it's online and available for consumers. As Larry mentioned, it is a challenge when dealing with many times, a country is at risk, but it might be a part of a country. So even in looking at Zika virus, you can't really use a zip code when you want a 4-block radius in Miami Beach. It becomes complicated. And so those are some of the issues. I think your cell phone knows if you were in the 4-block radius, but how that can actually get shared is something that needs to be explored. But it is something that was considered, and I think you're right that consumers could have this information, and if they find risk, could decide to share it. And we talked about that.
Is there someone still on the phone? Okay.
Troy Siegenthaler.
Troy.
Thank you very much. The commendable work. I mean, this is something that we absolutely need to be able to track and keep a close eye on, as well as anything else that comes up. My comment has to do with really looking at the support for the community health centers, federally funded community health centers, as well as the Title X family planning clinics. With the volatility that we see with healthcare reform and the American Health Care Act, the discussions about defunding a lot of those entities. My concern is this. I mean, while the majority of them, actually most of them, are on electronic health records and they are capturing data electronically, if the funding dissolves, I mean, we lose a lot of the population that goes to those centers. Most of our low income and a lot of our Medicaid patients, we will lose that. Were there any discussions about provisions in trying to, I would say, advocate that because of these disease outbreaks, different things that are population health managed in community health centers, as well as family planning centers, as to what we would do in those situations? I mean, what provisions do we have besides them being able to log onto a website and say, yes, I'm pregnant, and yes, I was in an area, and yeah, I did get a mosquito bite. What other provisions were discussed in the task force, or are we leaving it up to further discussions on down the line?
Yeah, so I'll provide some context, and it sounds like Annie has some things to say as well. So the first piece is we did talk broadly about providers and the whole host of providers that actually make it possible for people to stay healthy, manage their illnesses, including community health services of various kinds. But we also tried to really hold to our charge, which said it wasn't to us to advance either the broader health policy or the clinical guideline process, but really to provide the tools to enable that to happen. So we were trying to, if you will, to sort of finesse and focus on this is the things that we've really been asked to accomplish, but recognize the context of it really takes a very broad net to provide good public health.
Yes, I will add that I don't think we really addressed issues such as funding of healthcare institutions or medical care for people who need it, and some of this happened while the committee was actually doing its work, so we didn't explicitly discuss that. However, I will note that your point is a very good one, and that much of the care for many of these women who are exposed to Zika is occurring in, it's at least in New York City, in publicly funded hospitals and in federally funded health centers. And we did find that in New York City, at least, that there were some pretty significant disparities at the beginning in terms of who was receiving appropriate testing. And we did a major outreach campaign based on those disparities that were observed in order to ensure that the appropriate women with the actual risk of Zika were being tested and detected and tested appropriately. And I think some of these tools we're talking about could really help with that type of identification to prompt the questions to be asked, and could actually reduce the burden on the medical providers in those settings for ensuring that they're ordering tests appropriately, et cetera. So it's a major problem, but I'm hoping that some of the work that we're doing could reduce the time it takes to care for and do the appropriate testing to identify these types of conditions, and make sure that we do identify them in all the populations that are at risk.
I'd also like to put in a strong acknowledgement of the highly interactive, engaged, and maybe even coordinated efforts of both public and private areas to try to address this. So we had a lot of collaborative work with everybody from the government agencies, from CDC, from many of the other parts of HHS, from the vendor community, from the provider community, all looking to really come together and make this happen. Obviously, standards is a key piece on the technology side to make this happen. And so the funding in all of this is complex and interwoven. There was a lot of adoption that was funded through high-tech, but public health was not one of the recipients of the high-tech funding. And so, there's a question of getting the appropriate technology into public health to be able to act on the information that's becoming available. So there's a continuing need, I think, broadly to be looking at funding and lots of funding mechanisms here, but again, we didn't bring that into the work of the committee.
Just one other editorial comment I'll add is that these are really public safety risks. For example, we have rule out MERS cases show up in New York City. They can show up anywhere. They can show up in an emergency room in a public hospital. They can show up in a family health center, or they can show up in a very well-funded private hospital. We don't know where they're going to show up. And really, in order to detect the first case of MERS in New York City, we need to make sure that every patient who has a risk factor who might have traveled to the places where that is are screened appropriately and detected and reported to public health so the appropriate infection control measures can be taken. So this is, these examples will keep on coming, and I do think it's a really critical piece that if we can improve our ability to do this overall as these risks emerge, we will protect the entire public's health.
Great, thank you. And Gail, final comment?
Yes, I just wanted to jump into that subject matter on the public health issue, and I want to thank CDC for the work they did, especially on the Zika thing in Florida and what we have faced down there. But I also want to say that from the public health perspective, HITECH did not include dollars for public health, and it should have done so. I really felt it should have done so, and there are many states who do not have the technology or the wherewithal to purchase the necessary technology to do what needs to be done, and especially as we have emergent diseases that are so travel-related and that can be dispersed across the country very, very easily, Ebola, Zika, a variety of things. So I think that is something from the federal perspective that perhaps needs to be addressed is funding for state public health agencies to really have that coordinated approach across the country that would assist states, especially those who don't have the wherewithal to do it, and the technology there to do it. So I think that's an important issue this committee doesn't have purview over, but in the larger context of conversation on the issue, I think needs to be heard.
Thank you for that comment.
Thanks, Gail. And I'll point out that even though the HITECH didn't include funding for public health, Meaningful Use made the EHRs capable of sending information to the public health department. So that was one way that we helped to address that. I want to thank both the task force and the co-chairs of the task force for tremendous work, and point out this is a good exemplar. Coming to the end of our tenure in terms of the formal HIT policy and standards committee, of an important issue that involves the detail, that shows the details required in order to do good and to prevent tragedy. A condition that can affect half of the population of the planet and all the families around them and the offspring. So clearly something that's an exemplar of the unification of public and individual health. It's also a good opportunity. It was very heartwarming to see that the task force worked on the consideration of the workflow, as Dr. Fleming opened up. Certainly none of us physicians want to go back to the paper, because that was untenable and not good medical practice. But we also live in a world where we don't quite yet have the tools necessary either to share information with public health departments or to manage information in an appropriate way. So we certainly have that as our challenge ahead, both the sharing and the interoperability, as well as the appropriate management of information in ways that are useful, usable, and actionable, as you point out. So thanks again. And so we're ready to have a vote on the recommendations. I think I'll give Gail a chance to just phrase the consideration she would like to have as an update as we vote on it, because I would imagine that we want to have an amendment to the words that are already put there in order to incorporate her concerns that are echoed by other members of the committee. You want to?
Yes, I would just really recommend that we include some provision to have the discussion on privacy and how we address the specifics dealing with termination of pregnancy and how that might be included in a condition that would be reported, or especially if you're having lab data reported directly to public health, that could indicate there was a termination of pregnancy. I don't know how you might word that, and I think perhaps if you could come back with some kind of a recommendation and put that within your specific recommendations, that those privacy concerns be very carefully considered. And also want to offer the difference, the specific regulations state by state on consent dealing with that issue.
So let me try to incorporate that as an amendment to the approval motion and see if others agree with that. So is there a motion to approve the recommendations as amended by Gail? We need a motion and a second, then we can have discussion again.
So moved.
Was there a motion?
Second.
Okay, and now we're open for discussion. Kathy?
So I think it'd be helpful for us to have specific language that addresses the 2 points brought forward by Gail. And Gail, I don't know if you have crafted specific wording that you would like to propose to the group.
No, I have not. And what I would suggest, perhaps, if staff could come up with some specific language, we circulate. We do need to approve these recommendations, and we approve the recommendations and circulate the amendment for further approval, and that can be done via email. So rather than hold things up, we may not have another even electronic meeting, that can be done, and that those recommendations, that last recommendation could be somewhat wordsmithed as necessary through email. But the content being essentially addressing the 2 points of privacy and state consent and privacy laws.
Looking as a true legislator. So you were recommending that we approve the recommendations and circulate an approval, a draft for approval as an amendment?
Correct.
Okay. Let's have a re-motion for that then.
I so move.
Okay, and a second. Okay, any further discussion about approving the recommendations? And you know that there's an impending amendment to be circulated. Floyd.
And to perhaps avoid the need for that, perhaps just some wording that we recommend further analysis of privacy and national privacy and state consent issues, laws regarding pregnancy, and just that way we can just approve it today. Just a suggestion.
Kathy?
Or could I suggest some substitute language for that? Because I'm of the same mind. I think that, especially knowing that our tenure is short, and I think just adding that the task force and the committees acknowledge the need to address the state laws which may impact implementation of task force recommendations, and the further need to address the complex privacy issues related to pregnancy, period.
Are we, just a question, are we talking about specifically termination of pregnancy, or are we talking about pregnancy as a whole?
I think it would involve both.
Okay.
Right.
When that initial lab report comes in that there's a pregnancy, you don't know whether there's going to be a termination. But then if you have further reporting at that point, there would be an indication.
I would suggest, contra to that we focus more broadly on data that may be secondary to reportable conditions that may have some sensitivity attached to them, and address this as a more general rather than a specific point.
Other discussion about two alternatives. One is to have the amendment accompany the motion today. Another is an alternative amendment today or in the future. Sure, John.
John. Nope, now it's John. Just to be clear, does anybody think that the general gist of what Gail is getting at is a bad idea? Okay. So just however you phrase your recommendation, we'll follow it. Okay. So just as you think about parliamentary procedure. Thank you.
This is Michelle. Can I suggest, since I've heard a few different options, that it might be better to do over email so everyone can see it and we can work on revising it. But overall, it sounds like we've decided that, I'll let everyone vote, but that will be the next step.
So, I mean, that's consistent with what John said, which is the wide agreement about the need to be sensitive in this area, and let's get the words correct, pretty precise, so that recommendation and sentiment can be clearly communicated back to ONC and Dr. Fleming. Okay, Ann, did you?
So I have a new motion that I think will help with this. I move that we approve the current recommendations of that we have before us, contingent on email approval of language that to be submitted regarding pregnancy and privacy concerns or some such thing. Okay? Is that a reasonable motion?
Yes.
To have approval contingent?
Yeah, so we are approving this, and I mean, I don't know what you know what word you want to put in there, but we approve this, and we expect also to approve language related to concerns regarding privacy and termination of pregnancy.
And so just to jump in, I think what we've done on occasion in the past is something similar, where the recommendations are approved on their face now. Well, we can add in a little bit of a sentence or two or whatever is needed to address this point, noting, I think, Arian's point about the sensitivity in general of certain types of data in this space, and we can share it by email and get final thoughts on that before we submit it. But I think where we land based on what I'm hearing, is that we'd have the recommendation approved today. We can fine-tune that bit of language, add it in before the transmittal letter goes forward.
Yeah, I think that's what we have done in the past, and that's a cleaner, in my view, way of doing this.
And I think we need to withdraw the existing motion on the table and restate the motion. I withdraw my motion.
Okay. I think the original motion was that we would approve the recommendations with the further instructions to the task force to develop precise language that incorporates the concerns raised by you.
I so move.
Okay, thank you. And a second? Any further discussion? And I think both the ears and the minutes will reflect what we've said, and I think we can work this out and follow up. So all in favor, please say aye.
Aye.
And any opposed? So was the aye?
Can I ask for the folks on the phone, if you're in the webinar, if you can use there's the green and the red, if you can use those so we can tell how people are voting, it'll be easier. Thank you.
So people on the phone, please vote. And then I'll ask for any abstentions or nays. Okay, motion passes, and thank you very much to the task force members and to the co-chairs. Thanks very much.
Thank you.
At this point, I think we're going to break for lunch. Michelle?
We have public comment first.
Sorry.
So if there's anyone in the room who would like to make a public comment, please come up to the table. As a reminder, public comment is limited to 3 minutes, and I will turn it over to Jim to open up the lines to see if there's anybody on the phone with the public comment.
Okay. If you would like to make a public comment and you're listening via your computer speakers, please dial 1-877-705-6006 and press star 1. Or if you're listening via your telephone, you may press star 1 at this time to be entered into the queue.
We'll wait 1 more minute for folks on the phone, but while we do that, we're going to break a little bit early for lunch.
Actually, can I just make this?
Yes.
Yeah. So also, while we're waiting for comments, John White again. I had somebody ask me a question while this has been going on, just to be a little bit more clear about Dr. Fleming. So Dr. Fleming is here as the Deputy Assistant Secretary for Health Technology Reform. Dr. Fleming will be reporting to the National Coordinator. Obviously, we don't have a National Coordinator appointee yet, which is why I'm sitting here being the acting. But at such time as that happens, that'll be the working relationship. I think those of you who have worked with ONC over a long period of time know that, we're a team. So that, John is part of the team. But just in terms of the actual structure of ONC, that's the structure. So appreciate the request for clarification.
Thank you, John. So it looks like we have no comment in the room and no comment on the phone. So we'll break a little early for lunch, and we'll come back at 12:35.
Thank you, everyone.